The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. My name is Seth Huntley. I'm with OCO Communications. We act as the social marketing team for the National Native Network. On behalf of the National Native Network, I would like to welcome you to today's National Native Network Cancer Risk Reduction in Indian Country webinar, Chronic Hepatitis B, C, and forgive me if I mispronounce any of these words, Hepatocellular Carcinoma, Etiology, Risk Factors in Primary and Secondary Prevention. Your presenter today is Dr. Brian J. McMahon, MD, MACP. Brian J. McMahon is a clinical hepatologist at the Scientific Program and Clinical Director of the Liver Disease and Hepatitis Program at the Alaska Native Medical Center in Anchorage, Alaska, and guest researcher at the Arctic Investigations Program of the Centers for Disease Control in Anchorage. He directs a patient care program for over 1,200 Alaska natives with chronic hepatitis B and 2,400 with chronic hepatitis C. He conducts research on long-term protection studies on hepatitis A and B vaccines and management of chronic hepatitis B and C. He's the co-author of the American Association for the Study of Liver Disease, AASLD, U.S. Practice Guideline on Chronic Hepatitis B, and co-chair of the World Health Organization Hepatitis B Guidelines Committee. He was a member of the Institute of Medicine Committee that published recommendations for hepatitis and liver cancer in 2010. He has more than 125 peer-reviewed papers and 50 books, chapters, review, articles, and editorials. The objectives for today's webinar are to describe the rise in rates of hepatitis B, C, and again, forgive me if I mispronounce, hepatocellular carcinoma among AI-AN populations in the United States, and specific AI-AN subpopulations experiencing high rates. To identify which groups to test for hepatitis B and C, and to follow persons with hepatitis B and C and determine what to make referrals. To identify which persons have the highest priority to treat for hepatitis C, and to describe which groups need regular surveillance with liver ultrasound to detect hepatocellular carcinoma at a treatable stage. Funding for this webinar was made possible by the Centers for Disease Control and Prevention, DP 13-1314 Consortium of National Networks to Impact Populations Experiencing Tobacco-Related and Cancer Health Disparities. Webinar contents do not necessarily represent the official views of the Centers for Disease Control and Prevention. So, if you notice on the screen, there is the faculty disclosure statement. No commercial interest support was used to fund this activity. And the IHS Clinical Support Center designates this live activity for 1 hour of AMA, PRA, Category 1 credit, and 1 contact hour for nurses. To obtain a certificate, you must attend the entire webinar and complete the post-webinar survey that will be emailed out shortly. Questions and answers will be posted at the end of the webinar in the last few minutes. At that time, if you have audio capabilities, you can raise your hand to the GoToWebinar panel, and I will unmute you individually. And the reason we do that is to prevent audio feedback. Or if you do not have audio capabilities, you can type your question, and I can then read it to Dr. McMahon. And at this time, I will be turning the time over to Dr. McMahon. And let's see. Dr. McMahon?
Slides on the screen there. Yes, hi. Can you hear me?
Yes, sir. Click Show My Screen, if you would.
Okay, we just show my screen. Let's see.
All right. And yes, we see your slides. Yes, sir.
Okay, great. All right, well, thank you very much for inviting me to this webinar. My topic is hepatocellular carcinoma. I don't have any disclosures. What I'm going to talk about today is, first I'm going to talk about the epidemiology of hepatocellular carcinoma in the world, in the U.S., and specifically in American Indian and Alaska Native peoples. I'll talk about the different etiologies of HCC, which is the abbreviation for hepatocellular carcinoma. What are the risk factors for HCC? And what about prevention of hepatocellular carcinoma, both primary and secondary prevention? And then screening for hepatocellular carcinoma to prevent death and disability from cancer, for early detection of the cancer and removal of the cancer. And then finally, the treatment of hepatocellular carcinoma. So in the world, primary liver cancers have increased over the last 20 years from about 470,000 reported cases in 1990 to over 700,000 in 2002. Interestingly, that the incidence and mortality rates for liver cancer are actually decreasing in some of the higher intermediate incidence parts of the world, including China and Japan. In China, that's probably related to wide-scale vaccination for hepatitis B and also identification of people with chronic hepatitis B who need to be treated. And Japan, it's primarily related to early detection and treatment of hepatitis C. But in some of the low incidence areas, including our country, the United States and Canada, there is actually an increase in the incidence of hepatocellular carcinoma over the last couple of decades. So here's a map of the world showing the lowest incidence areas and the highest incidence areas. And some of these areas that are low incidence, they're actually not accurate because there is not a lot of data that's been published about these areas. But you can see in the United States, the incidence is less than 6 per 100,000. And in some countries in the world, especially in China and parts of sub-Saharan Africa, it's approaching 100 incidence of 100 per 100,000 per year overall in the general population. But here you can see in the United States that the actual incidence of hepatocellular carcinoma has tripled over the last 20 years, 20 or 30 years. But fortunately, survival rates have gone up, mainly due to better early detection and better treatments for hepatocellular carcinoma. So hepatocellular carcinoma is one of the indications for liver transplant, and we'll talk about that in more detail later. But you can see that over the last decade, the incidence of hepatocellular carcinoma patients being listed for liver transplant has gone up dramatically, and the relationship of hepatocellular carcinoma listing to transplant caused by hepatitis C has also gone up. So what do we know about American Indians and Alaska Natives? Well, there's one publication that was done a few years back. There's one publication. I'm first going to talk about liver disease in Alaska Natives and American Indians. And there's a recent publication that was just published this year looking at the actual death rate from chronic liver disease of all causes, including hepatocellular carcinoma, in American Indians and Alaska Natives, and comparing that to non-Hispanic white people. So now on the bottom blue line is the actual death incidence in non-Hispanic whites, which you can see has only slightly increased and not statistically increased. But in Alaska Natives and American Indians, that rate of death from chronic liver disease over the last 10 years has gone up dramatically, and now it was 2 times higher than non-Hispanic whites back here in 1999. It's now approaching 3 times higher than non-Hispanic whites in 1999. And among those causes of death is hepatocellular carcinoma, and it looks like in certain age groups the incidence of hepatocellular carcinoma is higher than it is in non-Hispanic white people, as you can see here, especially in the elderly age groups. So if we look overall in the world, what is the annual incidence of hepatocellular carcinoma for different types of liver diseases? Well, overall, for all people with hepatitis B, if we look at the people that are at the higher risk by age, which includes females over 50 and males over 40, and there's a decade difference here related to the fact that female hormones during the menstrual cycle of a woman's life are actually protective against hepatocellular carcinoma, and the incidence really rises dramatically after menopause. So the incidence per 100,000 per year is between 0.3 and 0.6 for females over 50 and 0.2 and 0.6 for males over 40. And then if a person with hepatitis B also has cirrhosis, that incidence goes up dramatically to 3 to 8% per year. With hepatitis C, the only risk factor in hepatitis C is patients who have cirrhosis, and unlike hepatitis B, where liver cancer can occur without cirrhosis, that's not the case in hepatitis C. But if you have cirrhosis with hepatitis C, that incidence is 3 to 6% per year, similar to what you see with hepatitis B and cirrhosis. We don't have good data on the incidence in hepatocellular carcinoma in patients with underlying alcoholic cirrhosis, nor with underlying non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease, part of the metabolic syndrome, diabetes, obesity, leading in some patients, but not all patients, to active liver inflammation and cirrhosis and hepatocellular carcinoma. But the data that we have, excuse me, I need to go back here. Let's see if I get this back. The data that we have is, we don't have data to actually give that incidence rate, nor do we have the data to give the incidence rate for autoimmune hepatitis, another disease that can cause cirrhosis, and we have very high rates of autoimmune hepatitis in Alaska Native population, the highest in the world. And I would suspect that it also may be high in American Indians. It's oftentimes not diagnosed, but autoimmune diseases such as lupus and rheumatoid arthritis are known to be very high in American Indians as well as Alaska Natives. So we would expect that autoimmune hepatitis and other autoimmune disease would also be high. Same with primary biliary cirrhosis. Alaska Natives have the highest rate of primary biliary cirrhosis in the world, and we do have data on that the incidence of liver cancer in primary biliary cirrhosis is quite high, 3 to 5% per year. So in our population here in Alaska, where we've done a lot of epidemiologic work, we know that the main causes of hepatocellular carcinoma in our population, number 1 is chronic hepatitis C. Number 2 is chronic hepatitis B with or without cirrhosis. Number 3, alcoholic liver disease, then non-alcoholic liver disease, and then autoimmune hepatitis and primary biliary cirrhosis. So interestingly enough, in Alaska, what's happened, is that we have seen the incidence of hepatitis B actually drop significantly since 1974. It doesn't quite look like it with this graph, but it actually is significantly fallen. And the incidence of hepatitis C has risen above that of hepatitis B since 1984. And we were unable to document any cases of hepatitis C liver cancer prior to this date. We actually sent tissue and serum from all the known patients that had been detected by our cancer registry to the NIH to do a molecular biology, PCR, looking for hepatitis C RNA, and none was found. So the first case occurred after 1984, and now it has increased above that of hepatitis B. And the reason that hepatitis B has gone down is because universal vaccination, which I'll talk about later, in the Alaska Native population, as well as screening for hepatocellular carcinoma and early treatment for hepatocellular carcinoma. So using a recent article published about 5 years ago, tried to look at what is the incidence of liver cancer in American Indians and Alaska Natives. In this particular study, they looked at registries both from the CRR program of the National Cancer Registries of the CDC, and also looking at the NCI CRR program. And they looked at, and then they crossed those programs, those registries, with the IHS enrollment records. And then they looked at the incidence and found that the incidence of Alaska Native peoples was higher than that in non-Hispanic whites, so higher rates of liver cancer. And that incidence in males was average about 7.3 per 100,000, and the highest rate was up in Alaska Natives at 17.2. This is actually the relative risk, or the attributable risk. And in females, it was 3.8 in the eastern tribes to 6.9 in Alaska. And this trend was increasing even though it was higher, it was not statistically significant except in Alaska. The other thing that was found in this study is that American Indians and Alaska Natives who developed hepatocellular carcinoma were less likely to be diagnosed in an early stage at a time which potential cure or treatment could be initiated, except in Alaska, where we've actually had a screening program for liver cancer for the last 30 years. And so this just shows from this study that the incidence of liver cancer was much higher in American Indian and Alaska Native men than it was in non-Hispanic whites, and in females, while lower than males, it was still higher than in American Indians and Alaska Native than in non-Hispanic white people. So what are the factors? Now I'm going to go through the different etiologies and what are the factors that contribute to hepatocellular carcinoma in each of these conditions which predisposes people to developing liver cancer. So with hepatitis B, it's primarily getting the infection early in life, either at birth, at which time if a mother is positive for the virus and the baby is not vaccinated right at birth, then the risk of the baby developing chronic hepatitis B is up to 90%. Or if a person is infected after birth in the first 5 years of life, there's a 30% risk of that person becoming chronically infected. After 5 years, that drops off to about 5 to 7%. Also, when a person with chronic hepatitis B reaches an older age, 40 for men, 50 for women, that incidence goes up exponentially of hepatocellular carcinoma. And again, as we looked at in an earlier slide, the presence of cirrhosis increases the incidence versus non-cirrhosis. But it's really important to know that in hepatitis B, it's really the only liver disease where liver cancer, primary hepatocellular carcinoma can occur in non-cirrhotic livers. Persons with a family history of hepatocellular carcinoma who also have hepatitis B are extremely high risk. Aflatoxin exposure, which fortunately we don't have in the United States, but is present in sub-Saharan Africa and Asia, increases that risk. If a person is hepatitis B E antigen positive, especially later in life, that risk is higher. And also for persons who are over 40 that have high levels of HBV DNA, greater than 20,000 international units, they're at a higher risk. And in Alaska and other parts of the world, we found that genotypes C and F predispose people to a higher risk of hepatocellular carcinoma. There are certain commercially available, I'm mentioning this because these are commercially available tests. I don't recommend ordering them because they're difficult to interpret, but the presence of the pre-core mutation actually may decrease the risk, whereas the core promoter mutation may increase the risk. And then if someone also is also infected with hepatitis C and hepatitis B at the same time, or delta hepatitis, which is a small plant-like virus which can only infect with hepatitis B at the same time, that increases the risk of hepatocellular carcinoma. So there was been a classical study that was done in Japan, a population-based study looking at persons starting in their early 40s over the next 12 years and looking at the incidence of hepatocellular carcinoma related to the amount of virus that's found in their blood. And if they had a low amount of virus, less than 10 to the 4 copies per ml, you can see the incidence was quite low. And as the level of virus at the beginning of the study was higher, than the incidence and the risk of hepatocellular carcinoma went up very rapidly. So viral load is really important, especially in patients over 40. In hepatitis C, as I mentioned before, you don't have to worry about hepatocellular carcinoma until that person develops cirrhosis, or what we call bridging fibrosis, which is a pre-cirrhotic lesion. At that point, people are at increased risk of liver cancer, but when they have mild or minimal amount of scarring or no scarring, that risk is really not much different than the general population. However, patients, as I mentioned before, that are co-infected with hepatitis B, that increases the incidence. And there's weaker evidence of increased incidence in patients with both Hep C and HIV, whereas there is evidence that the combination of these two increases the risk of developing cirrhosis. Now, In hepatitis B and C, both alcohol has synergistic effects on the development of cirrhosis, leading to an increased risk of hepatocellular carcinoma. Tobacco use has been shown in a number of case control studies to be associated with increased risk of hepatocellular carcinoma. And recently, diabetes and obesity are independently risk factors for the development of liver cancer. So here is a meta-analysis of a number of different studies looking at cancer in obese patients, showing that different kinds of cancers in obese patients, and showing that the greatest risk of all of these cancers, which are higher than 1, is liver cancer. And so people who are obese and have diabetes are much higher risk of getting liver cancer than they are at higher risk of getting all these other different cancers. And here's another study showing the incidence of hepatocellular carcinoma over a 14-year period in persons with and without diabetes. So again, you see this twofold increased risk in diabetic patients over non-diabetics. So if we look at what is causing liver cancer in the United States, and what are the attributable factors, and what are the proportion of liver cancers that are caused by the different etiologies. In general, in the United States, the prevalence of hepatitis B, except in persons born in endemic countries like Asia, Africa, South Pacific Islands, etc., in the general population, this prevalence is quite low. But it accounts for about a quarter of the cases of liver cancer in the United States, because most of these cases are occurring in people who've immigrated to the United States, were born in other countries such as Africa and Asia, and then get liver cancer while in the States. So the current prevalence of HCC due to hepatitis B is about 10 to 15%. And the population attributable fraction is around 5 to 10% of the entire cases of HCC in the population. Looking at hepatitis C, that incidence is higher. Actually, it's probably closer to 3% in the general population, especially in baby boomers, where it's 3 to 4%. That estimated risk is about the same as hepatitis B, but the prevalence of cases due to hepatitis C is much higher, and the attributable risk accounts for about a quarter of all the cases of liver cancer in the United States. We look at alcoholic liver disease. We know the prevalence in the general population of alcoholic liver disease is quite high, but the risk of HCC appears to be much lower in alcoholic liver disease, and the prevalence of HCC cases is around 30%, and the attributable risk is 20 to 30%. And if we look at the metabolic syndrome, and to me this is the scary one of the future, we can see that in the general population it's quite prevalent. 40% of Americans have metabolic syndrome and probably have fatty liver. The estimated risk for HCC is higher, is about the same as alcohol, maybe a little lower, but the current prevalence of HCC cases has risen dramatically due to the metabolic syndrome, and it accounts for 30 to 40% of all cases of hepatocellular carcinoma in the United States. So how can we prevent hepatocellular carcinoma? Well, we can prevent hepatitis B infection and have a dramatic effect by vaccinating children and even adults, which we've done in Alaska. And we've seen from studies in Taiwan, Thailand, and Alaska a decrease in the incidence of HCC in children already from mass vaccination programs. Whatever the etiology of liver cancer is, if we can treat the underlying liver disease, we can decrease the risk of developing liver cancer. Also, in our patients in Alaska love this, coffee has been shown to be highly protective against development of hepatocellular carcinoma, and not only in case control studies, but also in well-designed cohort studies, including an NIH study. It looks like perhaps that statins and metformin may be protective, and this may be important for people with a metabolic syndrome and diabetes who have hyperlipidemia, but we need more data on that. And we know that if we screen for hepatocellular carcinoma in those patients at risk, we can improve survival once the cancer is diagnosed. So how can we reduce the risk of HCC? Well, as I mentioned before, if we can treat the underlying cause of cirrhosis or hepatitis, we can actually decrease the risk. Antiviral therapy for hepatitis B for those who meet the criteria, and the criteria are listed here on the US AASLD guidelines, and you can download these for free. If you follow these criteria and you treat people who need treatment, not everybody needs it for hepatitis B, there's now beginning to appear studies showing that you can decrease the subsequent risk of liver cancer. Curing hepatitis C, that's one of our biggest challenges, and there's several cohort studies showing decreased risk of developing liver failure, liver cancer, as I'll show you in a minute, in curing patients with hepatitis C. Weight loss and exercise for persons with the metabolic syndrome will improve the scarring of the metabolic syndrome in those people who are going to develop cirrhosis, but we don't have long-term data on reduction of HCC. We have to make a leap of faith here. And abstinence from alcohol can improve alcoholic liver disease and even reverse cirrhosis if it's early, and probably decrease the risk of liver cancer. And then targeted therapy for autoimmune hepatitis and primary biliary cirrhosis, we think can also reduce the risk of HCC. So here in Alaska, when we did universal immunization of all infants and children and adults starting in the early 1980s, we immunized over 85% of the population were screened and vaccinated. We detected a lot of carriers of hepatitis B, including over 450 children who were infected, but the universal and catch-up vaccination program has eliminated hepatitis B carriage from children in Alaska. They are now free of hepatitis B infection. Everyone under 20 is negative for hepatitis B. And also, we've shown that liver cancer, which was the highest rate in children in the world, reported from Alaska, has disappeared. And no longer do we see hepatocellular carcinoma due to hepatitis B in children. So vaccination works. Now, what about treatment of hepatitis C? Well, there's been several studies, and this is just one of them, showing patients who were cured. SVR means sustained virologic response. We can now use the C word, the cure word, and you can see that if you were cured of hepatitis C, here's your risk of liver cancer over 16 years versus those who were treated and were not cured. And this is in the days of pegylated interferon and ribavirin. And again, this also shows, this is the cumulative incidence, and this is the incidence in persons under 65 and over 65 years of age. And a study in hepatitis B, which was done in Taiwan, with persons who had cirrhosis, randomizing them double-blind to lamivudine versus placebo, showed a decreased risk of liver-related death, liver decompensation, and hepatocellular carcinoma in those persons who got lamivudine. They had to stop this study prematurely because of the significant difference, and the ethical committee asked them to stop the study early. And this study would never have been able to be done in the United States, but it does show that treating hepatitis B patients with cirrhosis can decrease the risk of hepatocellular carcinoma. So now that we've shown that there's ways that we can vaccinate against hepatitis B and prevent liver cancer in those patients, and we can treat the underlying causes of liver disease and decrease the risk of subsequent hepatocellular carcinoma, what about those patients who are at risk or remain at risk for hepatocellular carcinoma? What about trying to detect these cancers early? So there's a practice guideline also by the AASLD, which is the Liver Society in the United States, and you can get it on their website right here for free, download it under practice guidelines for hepatocellular carcinoma screening. And what this recommendation says is that surveillance, meaning regular screening for hepatocellular carcinoma, should be performed primarily using ultrasound, and it should be every 6 months. And shortening the surveillance interval doesn't really seem to increase detection of HCC early. So every 6 months is adequate. So who do we look for to screen for hepatocellular carcinoma? Well, if we're looking at the evidence that screening works or doesn't work, we don't have any randomized controlled trials in cirrhosis or in hepatitis C. We do have 2 randomized controlled trials of screening versus no screening in hepatitis B. Both were done in China. One showed a significant benefit of screening, the other did not. And I think the reason this one did not was because in this particular study, they didn't tell those people who they screened. It was about 10,000 people that they randomized. They didn't tell them, the persons that weren't screened, that they weren't going to be, that there was screening available. They just screened those that were lucky enough to get into the screening arm and didn't say anything to those who didn't get into the screening arm. In this study, they did tell the patients when they enrolled them that you might get into the non-screening arm and the screening arm might show a benefit and you might not have that benefit. So the person, when they were randomized, many of the people randomized to the non-screening arm went to their provider and said, I want to get screened for liver cancer because I got into this study and they're not going to screen me. And that really goofed up their results, and I think resulted in showing no benefit because a lot of small tumors were detected early in the non-screening group. In the study that was randomized and did show a benefit, here's just showing a 5-year benefit in survival from hepatocellular carcinoma in the screened group versus the randomized group that wasn't screened. Now, there have been a number of screening studies that have been done looking for HCC. There are clinic-based studies, and those studies, almost all of them show a benefit that are on the right side of this line, which is the line for no benefit, and you can see that most of them showed significant benefit. So those studies give us enough evidence to say we should be screening high-risk persons. What about using alpha-fetoprotein? Well, alpha-fetoprotein is a serologic marker which is elevated in probably about 80% of patients with liver cancer, but it has low sensitivity and specificity. And especially in hepatitis C and even in B, it can be elevated just secondary to liver inflammation and liver cell regeneration. And persons with elevated AFP are at a higher risk of liver cancer, and it should be one of the criteria for saying this is a person I should screen. We use AFP in Alaska because most of our patients with hepatitis B live in rural, remote communities where ultrasound isn't available, and we found that it has a very high negative predictive value if the AFP is normal, but it's got a low positive predictive value. And I'll show you more of that in a minute. So what we do in Alaska is we screen AFP for all the persons with hepatitis B. And as I mentioned, hepatitis B in Alaska native population was mainly acquired at birth or in early childhood. Much like in Asia, it's endemic in the population in western Alaska. And we used alpha-fetoprotein every 6 months. And we also recommend ultrasound in those patients that have cirrhosis, that have a family history of HCC, that have a previous HCC diagnosis, or if they're men over 40, women over 50, and they live in a community where ultrasound is available. In some of our tribal hospitals in the rural areas, like in Bethel, Nome, Kotzebue, ultrasound's there, and that we send them a letter telling them to get ultrasound every 6 months. But in the other patients, we just send them a letter every 6 months. They live in a small village, tell them to get an ultrasound. If that ultrasound is greater than 10, we then send them to the nearest facility. It might be 200 or 300 miles away by plane, and have an ultrasound done, and then continue to do ultrasounds after that once they reach that cutoff of 10 AFP. And again, I mentioned about screening people with hepatitis B who live in communities that have ultrasound. With persons with hepatitis genotype C or genotype F, those patients are also at high risk of developing liver cancer, and if we have patients with those genotypes, we try to get them screened once they hit the age of 40, and anybody with a high viral load, we try to get them screened every 6 months also with ultrasound. So everybody gets AFP, but we're really trying to target the people at the highest risk of developing liver cancer to get an ultrasound because of the cost of transporting patients from villages into a community with ultrasound. There are over 130 remote villages that have one or more persons with chronic hepatitis B living in those communities. What about our other patients with other liver diseases? Well, We try to get everybody with cirrhosis, again, if they live in a community where there's ultrasound available, to get screened every 6 months, regardless of the underlying etiology of cirrhosis. And we do both AFP and ultrasound, and I think they're complementary to each other. I don't have time to really talk about that, but in Europe, in their European and Asian guidelines, they use both. The U.S. recommends only ultrasound. Now, in persons with hepatitis C that we don't know whether they have cirrhosis or advanced fibrosis, bridging fibrosis, we still do AFP in those every 6 months, along with liver functions. And if the AFP is greater than 10, we will do ultrasound every 6 months, but we also may do a liver biopsy to see how much liver disease they have and try to get them treated earlier than later. Because in most of the time when AFP is elevated in hepatitis C, it's related to a very active ongoing liver inflammation and fibrosis. And although it's a marker for future risk of HCC, it's not always associated or not very often associated with HCC actually being there at the time that it's first elevated. So in hepatitis B, jumping back to hepatitis B, how good has our program been over time? This is an old publication, but I'm updating the data in the publication. The sensitivity of AFP in the old publication was 97%, which was pretty good if it was above 15, if we excluded pregnancy. The positive predictive value was low, but significant 5-year survival was shown compared to historical patients who were not screened. Since 1982, when we started screening in hepatitis B, we found 53 cases of HCC. In 89% of those, we found them at a potentially curable stage. 34 of those were actually resected, and 13 of those were treated with alcohol injection, or now we use only radiofrequency ablation, which I'll also talk about in just a second. In hepatitis C, our studies have shown that AFP is a very good marker for showing who's at risk for developing HCC. No patient in our study who had an alpha-fetoprotein below 8 developed liver cancer over a 6-year follow-up period on average. But if the AFP was above 8, it had a low sensitivity but a high specificity for detecting advanced fibrosis, either bridging fibrosis or cirrhosis. And they had persons with end-stage liver disease or hepatocellular carcinoma had 158 times the odds of having an AFP greater than 8 compared to people who did not develop end-stage liver disease or hepatocellular carcinoma. So it's a marker for bad things to come if it's elevated. And the interesting thing is now there's reports of AFP, and we've seen this in our patients going down to normal once their hepatitis C is cured. So what about how do we diagnose hepatocellular carcinoma? Well, most people follow what's called the Barcelona criteria. And that criteria says that if you have 2 imaging studies with a compatible lesion like ultrasound CT or ultrasound MRI, that's enough to say take that lesion out or treat that lesion with ablation without getting a biopsy of the lesion. Or if you have one compatible study plus an AFP that's greater than 400, that's also criteria for just removing that lesion or treating that lesion without biopsy. Now, what's important is that you can make a very, very bad error by sending the patient with a hypoechoic, a less dense lesion found on ultrasound to your favorite radiologist and telling them to do a CT scan. Please don't ever do this, because I'll show you why you'll miss this cancer with a contrast, non-contrast CT. You need to get a triphasic or a quadriphasic CT scan. Or you can do a MRI with gadolinium. That's as good as doing a CT scan. So here is a quadriphasic CT scan from one of our patients. On the non-contrast study, you cannot tell there's a liver cancer here. So you inject the dye, and instead of waiting 45 seconds to do the contrast study, because most of the supply of blood from the liver comes from the portal vein, so the dye has to go around the circulation and come back again before it lights up. You do the first pictures at 10 seconds, and look at this tumor. It lights up like a light bulb. And then at 45 seconds, when the rest of the dye hits the liver, and the rest of the liver is lit up, this is washing out. The tumor's washing out, and if you do a delayed phase, the tumor has washed out. So these are the most important, triphasic, but quadriphasic is also great too. And here's the first hepatocellular carcinoma we ever diagnosed back in 1982. This person was 17 years of age. His person is now in his late 40s, almost 50. He has 4 children. He works for the school district in his village and has developed cirrhosis, which we've treated, and he did develop recurrence of cancer many, many, many years later, probably a new cancer which has been treated, and he's doing well at this time. So early detection can make a huge difference. Here's another patient who was 10 years old, asymptomatic, was screened for vaccination, found to be surface antigen positive, had an alpha-fetoprotein of 10,000. We were worried that it was too late for this little guy. And notice that this 5-centimeter tumor is right next to the hepatic vein. Another couple of weeks or months, and they would have invaded the hepatic vein. It would have been all over. This was resected by one of our surgeons because the patient did not have cirrhosis in his liver, and he is well and doing great 30 years later with no evidence of recurrence and no evidence of cirrhosis. He's on antiviral therapy. So again, the diagnostic algorithm for suspected HCC, if you have a liver nodule on ultrasound that's less than centimeters, just keep repeating, 1 centimeter, keep repeating that ultrasound. It's most likely a regenerative nodule in a cirrhotic liver. If it's increasing, then investigate it. If it's greater than 1 centimeter and it's hypoechoic, it doesn't look like a hemangioma or something else, then you want to do either an MRI or a 3 or 4 phase CT study and look for the hypervascular lesion to light up and then wash out later on. And then if you don't find the lesion compatible or there's some conflicting evidence, you might have to do a biopsy. And the problem with doing a biopsy, sometimes you can see tumor along the needle track of the biopsy. So we don't like to do biopsies unless we really need to, or we're going to ablate the lesion. So what are the treatments? Well, early tumors, especially if portal pressure is normal, and the way to do that is just ask on ultrasound to do a portal flow study, and they can tell you which direction the blood is flowing. If it's going in the normal direction, then you can take that tumor out, or you can ablate it with radiofrequency ablation. If the patient's got stable disease, if they have cirrhosis and there's concern about portal hypertension, you probably want to try to ablate the lesion or maybe consider listing them for transplant. The criteria for transplant is all the lesions have to be in one lobe of the liver, like the right lobe or the left lobe. There can be no more than 3 lesions, none of which can be greater than 3 centimeters, and the total diameter of all 3 lesions can't be greater than 7 centimeters. If they meet that criteria, they're a liver transplant candidate. If, on the other hand, if the tumor is bigger than can be resected, ablated, or transplanted, then you have to use chemoembolization. And then finally, if all else fails, there is a drug available, which I'll tell you why not to use this drug in just a minute. So again, this is just another staging for treatment. These are the curative treatments we've talked about: resection, liver transplant, radiofrequency ablation. All are potentially curative. These are the palliative treatments, and then the persons that have large tumors that have metastasized, symptomatic treatment is the only thing we have available. So radiofrequency ablation, which we've been doing at ANMC for more than a decade, is to put this probe in and then push out these little wires into the lesion, and then hook that up to a radiofrequency ablator, turn on the juice, and burn that tumor out completely with one treatment, and also about 1 centimeter outside the tumor. And this has high rates of cure if their lesions are small. And here is one study looking at radiofrequency ablation versus resection, showing no difference in liver function performance or tumor burden, no difference in overall survival, but much less morbidity and complications with radiofrequency ablation than surgery. So what about transplantation? Well, if they meet the Milan criteria, those criteria I told you about, then people do very well with a transplant. 5-year tumor-free survival with a transplant is 70%. So people who have cirrhosis get extra points on the liver transplant MELD score for having a tumor. And again, this is looking, next I'm going to talk about chemoembolization. That's putting a catheter into the hepatic artery and obstructing that with gel foam or a clot, or and putting in a chemotherapy agent, or putting in radioactive iodine beads. Those are all the ways of doing chemoembolization, and randomized trials have shown not a cure, but increased survival. And in addition, sometimes patients with bigger tumors that don't meet transplant criteria, the tumor can be downstage with chemoembolization, and they can become a transplant candidate. Well, what about sorafenib? Sorafenib is a monoclonal antibody that targets regenerating capillary vessels that are feeding the tumor. And this looks really darn good when you look at it, but just cover your eyes for a minute. Don't look at this. Looks great. Significant survival benefit for an expensive drug, but it's oral. But that survival benefit is 10.7 versus 7.9 months. So the survival benefit overall is less than 3.5 months, very expensive, and this is the reason not to use it. Makes people sicker than a dog. We've treated 3 patients. They all said, get me off this drug within 2 weeks. It's on our formulary. Our oncologist won't use this drug because it's so toxic for this particular tumor. It's better for other tumors than hepatocellular carcinoma. Unfortunately, all the systemic chemotherapy doesn't really work for hepatocellular carcinoma, so people are not going to get offered that, nor does external radiation. So in conclusion, the incidence of hepatocellular carcinoma in the United States is rising. The etiologies have changed over the last 20 years, increasing etiologies due to hepatitis C and non-alcoholic fatty liver disease. New risk factors for HBV have been identified. Surveillance for hepatocellular carcinoma. We're in Alaska. We use alpha-fetoprotein first, but ultrasound should be used if it's available and if people meet the surveillance criteria. AFP is a good surrogate marker for advanced fibrosis, and we desperately need better serologic tests. My final 2 slides is just to invite you to join our video teleconference, which is once a month. It's similar to Project ECHO, which some of you are on, but we cover all liver diseases, and it's available for anybody to tune in and get CU, CME credits, and here's the directions to do it. And also, we invite you to look at our website. We have lots of information. The website was funded by IHS, and we have an advisory board of people with hepatitis C that go over our website with a fine-tooth comb and give us lots of criticism, tell us what we can do better. It's constantly updated as new drugs come out. There's information for both patients and providers. There's a lot of other information on there too. So please check out our website. It's free, and you're welcome to participate in it. Thank you very much for your attention, and I'm happy to answer any questions at this time.
Thank you, Dr. McMahon. Questions for Dr. McMahon. As we said previously, you can press the button if you have audio capabilities and raise your hand on the GoToWebinar control panel. Or if you do not have audio capabilities, you can type your question and then I can read it to Dr. McMahon for you. So, questions? Give people a minute to type their questions. Okay, we did have one question so far. Someone asked about the presentation, and as with most of these presentations, not only will the slides be made available via Keep It Sacred as a PDF document after the webinar is finished, but also a recording of this webinar, so you can go back and review this webinar because I know there was a lot of information covered, And while I was trying to take notes, I'm sure I missed stuff as well. Other questions for Dr. McMahon? And we will be sending out the links for all of that information for those that have registered and attended today's webinar. I guess people understood it far better than I did. Well, we'd like to thank Dr. McMahon on behalf of the National Native Network, and we would thank you so very much for all the preparation that you've done for this webinar, sir. And are there any other questions or comments before we adjourn for the day?
Oh, you're very welcome, and thank you for inviting me. And also, you can email me if you have any other questions. I'd be happy to answer them. Again, we invite you to check out our website because there's a lot of information on there too.
Yes, sir. I will also put direct links to the website as part of the email that gets sent out to everybody that attended. I'll make sure to put all the information contained within those last 2 slides on there. And we would definitely encourage you to go to the website and to look at that information. And as Dr. McMahon said, it's constantly being updated. And also included in that email will be the evaluation for today's webinar. And we all know how important those can be. And if there are no further questions or comments, we will adjourn for